As we've learned throughout our course, DMD is a recessive X-linked disease characterized by progressive muscle weakness. DMD treatment and management requires multidisciplinary care, one of which is nutritional intervention. Several nutrition-related concerns include growth, body composition, energy and protein requirements, constipation, swallowing difficulties, and bone health. In a broad overview, as the DMD patient ages, nutrition intervention transitions from prevention of weight gain to concern for undernutrition. Over and undernutrition occur in approximately 54% of patients with DMD from 10 to 13 years of age. Overnutrition, or obesity, has been attributed to multiple factors such as decreased physical activity and ambulation, replacement of muscle with fat and connective tissue, and use of corticosteroid treatments. Deleterious effects of overnutrition impact glucose metabolism, mobility, and respiratory and cardiologic functions. Undernutrition has been attributed to feeding difficulties responsible for weight loss in DMD in the late teen and adult years, as a variety of chewing and swallowing difficulties are reported in DMD patients. Hyponutrition has negative effects on muscle and ventilatory function. Overall, nutrition is an important aspect of DMD treatment.
Let's discuss the physical changes that can affect the diet of a patient with muscular dystrophy. Firstly, as previously mentioned, patients with DMD do lose ambulation, resulting in decreased activity, and this, in conjunction with steroid treatment, can result in excessive weight gain. Being overweight can accelerate the disease progression due to the exertion of extra force on already weak muscle groups, increased respiratory involvement with worsening pulmonary and cardiac function, as well as deterioration of skeletal malformations. So, it's important that a patient's weight be monitored, especially after ambulation is lost. The patient's nutritionist or primary care provider should be making an individualized diet plan based on the physical activity level and the capability of ambulation that each patient has. Another important physical aspect to consider when discussing patients with DMD is their tongue and oral muscles in general, because you use a lot of muscles to chew and swallow your food, which, as their disease progresses, they might not be able to do. And patients with DMD are actually noted to have an enlarged tongue as well as tongue hypertrophy, and these both make chewing and swallowing much more difficult for the patient. So your tongue's super important for eating, obviously. Tongue dysfunction may induce inadequate bolus formation, mastication, and premature bolus loss, which all of these can cause pharyngeal residue or aspiration. And one study suggests that in regards to tongue thickness, in the early stages of DMD, the tongue tissue may be replaced with connective tissue or fat, and that as the disease progresses, the further tongue thickening is slowed because of this replacement. Thus, it's important that tongue dysfunction is monitored throughout the patient's life, and so that their diet and treatments can be modified as needed based on their tongue function. Tongue dysfunction can be measured with tongue thickness and maximum tongue pressure tests. A maximum tongue pressure test should be conducted routinely to monitor changes, as this will likely change more often than their tongue thickness. It's recommended that once a patient has a maximum tongue pressure between 10 to 25 kilopascals, they begin a dysphagia diet. It's important to discuss these tests and a dysphagia diet with a medical provider in regards to proper DMD management. As the patient's dysphagia continues to worsen, the level of diet is going to need to be changed and will ultimately progress to tube feeding, as it's important to avoid choking or aspiration if the patient cannot swallow properly on their own.
Nutritional management of DMD can come in the form of nutrient supplementation. One example of such is calcium and vitamin D treatment. Both the use of chronic corticosteroid therapy and the impacts of hyponutrition can lead to osteoporosis or other bone complications. Long-term therapy with corticosteroids involves unwanted side effects, such as loss of bone mass and increased risk of fractures. Reduced weight-bearing activity and muscle weakness also leads to consequent risk of fractures, osteopenia, osteoporosis, scoliosis, bone pain, and an overall poor quality of life. Therefore, one instance of nutritional intervention comes in the form of supplements targeting reduced bone mass and increased fracture risk. In a previous study, vitamin D and calcium intake management corrected vitamin D deficiency and increased bone mass in about 2/3 of cases. 33 children with DMD on glucocorticosteroid treatment were followed for 3 years, 1 of observation and 2 years of treatment. Bone mineral content, BMC, and density, BMD, were used as markers of bone health. After 2 years of calcifediol and calcium-rich diet treatment, BMC and BMD significantly increased in over 65% of patients. During the observation year, there were 4 fractures in 4 patients, while during the 2 years of treatment, there were only 2 fractures in 2 patients. Overall, this study demonstrates the effectiveness of nutritional management through supplementation on improving the quality of life in DMD patients.
Gastroenterology care encompasses management of constipation, gastroesophageal reflux, gastrointestinal motility concerns, and when gastrostomy tube placement is needed. Every 6 months, a gastroenterologist will ask a DMD patient and his parents questions about these issues and takes action as necessary. Next, we'll go into risk factors and treatments based on the specific digestive issue. Constipation in DMD patients is frequent. Some risk factors for it are slow movement of stool through the colon, lack of body movement, abdominal muscle weakness, and dehydration. Treatments for constipation include daily laxatives or, in more severe cases, retrograde enemas for fecal impaction. Gastroesophageal reflux is when stomach acid reaches the esophagus and causes pain and damage. Risk factors for this are scoliosis due to weak back muscles, lack of motility of the esophagus, gastroparesis, and glucocorticoid therapy. There are 2 types of treatment for this that include dietary treatment, which are eating multiple small meals throughout the day and decreasing fat intake. Drug treatments include histamine 2 receptor antagonists like ranitidine and protein pump inhibitors like lansoprazole or omeprazole. Although protein pump inhibitors come with risks such as pneumonia, kidney disease, and bone fractures, so they may not be a good option for all patients with reflux. Gastroparesis is a delay in gastric emptying. The risk factors for this are progression of skeletal muscle weakness. Symptoms are abdominal pain, nausea, vomiting, and loss of appetite. Treatment includes a change in diet, medications, and finally, in severe cases, a gastrostomy tube inserted into the jejunum. Gastrostomy is the placement of a feeding tube into the jejunum that allows nutrients to bypass the mouth, esophagus, and stomach to reduce harsh gastroenteric symptoms and issues. Gastrostomy stabilizes nutrient uptake but is a surgery, so it is necessary to make sure pulmonary and cardiac function in the patient are strong enough. A gastrostomy tube is placed if one or more of the following is occurring: dehydration and weight loss, malnutrition, aspiration, or moderate to severe dysphagia. Gastrostomy can ultimately be very helpful in DMD patients with severe digestive issues, but needs careful consideration due to other health issues and the ever-present risk of anesthesia and a harsh recovery process. Gastroenterology is an important part of providing more physical comfort for DMD patients and improving their prognoses. All in all, dietary and digestive tract considerations are an important part of DMD treatment. As we learned today, there are several issues regarding diet and digestion that can be treated to improve the quality of life of these patients. To further improve the overall health of DMD patients through dietary and digestive tract treatment, a few things need to be considered. First, since 50% of DMD boys are obese by age 13, MD-focused obesity treatment would improve prognoses and movement. Second, we need to do more research on resting and active calorie expenditure to determine the ideal amount of food intake and activity level for these patients. Lastly, we need to better understand amino acid supplementation to potentially improve the efficacy of gene therapies. We also should research the effect of different amounts of protein intake as well as fructose intake on the muscles and the overall impact of a tailored diet and supplementation regimen on the quality of life and prognosis of the patient. We hope you enjoyed this additional information about Duchenne muscular dystrophy treatment. Thank you.